Good evening, everybody, and welcome to this ESSM webinar. I'm very happy and I'm very proud that we keep doing this. My name is Mikkel Fode. I'm the educational chairman of our society, and I'm particularly excited about the webinar we're going to have tonight on non-organic erectile dysfunction. I will start by giving the word to our president, Carlo Bettocchi, who's going to say a few words, and after that we have our scientific chairman, Giovanni, who is instrumental in organizing these webinars. After the webinar, just want to say this now, we're going to take questions. So during this whole time, you're very welcome to put in your questions for the speakers into the question box or the chat. We'll collect them and have a nice discussion at the end of the webinar. So thank you for being here. And Carlo?
Thank you, Mikkel, and thank you everybody for being with us tonight. And thank you, IBSA, for making possible really to support this very interesting webinar that is going to host two of our most outstanding speakers, both Emmanuele and Marieke. They are really some of the best speakers that we can offer in terms of scientific interest effort. I think that it's just a matter for me to give you really my introduction as a president. And as you know, our society is deeply involved. So this is just the title of today, as Mikkel said, management of non-organic erectile dysfunction. And we got both two big expert opinions to be listened to. But I'm going to leave this later on, the introduction to Giovanni, that together with Mikkel are our motor, the people that are moving on our society in terms of both scientific and educational context. And I'm very proud really to be part of this team because as you can see from the following slides, we are very much involved in educational program. And this is our newborn educational program that we have just finalized in the last month, and it's ready to start in the second half of the year. And as you can see, is mainly focused for surgical people. And in fact, we have designed a 4-level sort of comprehensive way to learn how to manage penile prosthesis mainly. And we move from an online webinar that will be open for all our members to a textbook and video library that will more focus for people who are interested in surgery. And then only few people will move on the 3rd and 4th level that will be basically based on a 3D model surgery. And finally, with a fellowship in our centers of excellence. Next, please. You also know that we are continuing doing our, next slide, please. We are continuing to do our program with the scientific journals. And this is another new program that started last year called ESCAP, and is our scientific collaboration and partnership with using young people with some important international journals. The aims of this initiative is to connect the well-known sexual medicine experts from different societies, so not only our society, with the young talent authors that are trying to grow up and do as much as possible publications and research. And we have already started, we have already get published the first article, and we are moving and working on some other programs that are already on the way to be published. Next slide, please. We are still running our ESSM School of Sexual Medicine, and from this year will be also the advanced course on sexual medicine. You know that we have 1 year, unfortunately, that we were unable to do it due to the pandemic COVID condition, but we are ready to start again in Budapest next year, November 2022. And so all participants will have the opportunity, as you already know, to learn the most important things in the field of sexuality, and especially to have a very nice and familiar time together with the faculty. And this is very good not only to learn more in this field, but also to get more involved and more close to these people. Next, please. We are running also the new upgrade or update to our manual sexual medicine. We are trying to get it ready for 2022 possibly, and we are also working on the syllabus of clinical sexology, but of course it needs a little bit of time to upgrade both of these important manual that we have started to write in 2013. And we have done, and it's published already, the textbook on surgery, and this will be part, as I told you before, of the advanced course on surgical field, the surgical field. Next, please. So, last slides for me is to give you this preview. We have 2 more webinars already scheduled in collaboration with IBSA. And so really, thank you very much, IBSA, for your support, and stay tuned, because I'm sure that you will enjoy as today with us and together with our faculty. Thank you very much. And I think that Giovanni is going to follow me.
So thank you, Carlo. Thank you, Mikkel. We are more than 120. So again, a great success for this series of webinars. As Carlo said, this is the first one. There will be other 2 webinars after summers. Again, thanks to IBSA to support these educational activities. As Carlo said, we have no words to introduce these 2 fantastic and fascinating speakers. Marieke Dewitte, psychologist from Netherlands, the secretary of the European Society for Sexual Medicines, deeply involved in the educational and scientific activity of the society. So well-known speaker approaching and addressing the management of non-organic erectile dysfunction. And the second one, a close friend of mine, a past president of the Italian Society of Androgen and Sexual Medicines, the chief of the publishing committee of the International Society of Sexual Medicines, and deeply involved again in the scientific activities and educational activities of the European Society for Sexual Medicines. So it is my pleasure to introduce these fantastic speakers. I'd like to remind all of you that you can, during the presentation, write using Q&A or the chat. You can write questions, and I'm sure that at the end of the presentation, both speakers will be available to address your questions. So, Marieke, please, the web is yours.
Thank you for the introduction and for the kind words. So, today, me and Emmanuele are going to talk about management of non-organic ED. And I will start this presentation, and then further on, Emmanuele will elaborate on these topics. So I will start with a broad overview. I think it's really important to consider that ED involves a disruption of vascular, neurological, hormonal, and psychological factors. So it's clearly important that it's a physical symptom, but psychological factors are always involved in case of erectile dysfunction. And for a long time, there has been a focus on looking for biomedical markers, biological markers of ED, which has to do with the easy and wide access of medical treatments. But slightly we move on towards a more biopsychosocial model of erectile dysfunction, because we have to realize that psychological and relational factors are always at play, even in case of organic causes. So it's actually not really relevant to differentiate between organic and non-organic ED. It used to be the case that we wanted to know the etiology, and when it's an organic cause, we present an organic treatment, a medical treatment, and when it's a non-organic cause, we present psychotherapy. But in fact, the treatment is not cause specific, and this is what we are going to address in this presentation, because the combination of psychotherapy, counseling, and medical treatment is important because of this biopsychosocial nature of erectile dysfunction. So when we look at the etiology, we adhere to this biopsychosocial model, and obviously the biological factors are well known. But let's focus a little bit more on the psychosocial factors, which are less known and less investigated in the field. So according to the cognitive model of Barlow, attention and cognitions play an important role in causing and maintaining erectile dysfunction. So what happens is that men with erectile dysfunction enter a sexual situation with high negative affect, low positive affect, negative expectancies. They have this expectancy that they're going to fail, that it's not going to work. So they're hypervigilant to threat. There's an attentional shift. They monitor themselves constantly. So they're not really focusing on the sexual and erotic cues, but they're focusing on themselves, on the very mechanical aspects of sexuality. And this evaluative focus on the self creates performance demand, creates anxiety, which then increases sympathetic nervous system arousal, which then decreases the genital arousal. So this actually confirms the fact that they're losing their erection because they lose their sexual arousal. And as a result of this confirmation of failure, they start to disengage from and avoid sexual activity. And because of this avoidance, they actually keep on associating sexuality with negative affect, low positive affect, and these negative expectancies. So here you clearly see that men with ED actually enter a vicious circle. And this is independent if you have an organic cause or non-organic cause. It doesn't matter, because these mechanisms, these psychological cognitive mechanisms, are involved in maintaining and exacerbating the erectile dysfunction. So you can clearly see that performance anxiety plays an important role. Men have the idea that they need to perform. They're anxious that they're going to fail, that their penis will not be erect enough. And there's the spectatoring. This is what we call this self-evaluative focus. This monitoring of yourself is actually that you're kind of looking at yourself during sex. So you're not really involved in the sexual stimulation, which causes cognitive distraction. We also know that there are a lot of negative automatic thoughts, like I'm a failure, I will fail, I need to perform, and also these rigid macho beliefs, unrealistic expectations of male sexual performance. And if we look at these myths, these macho beliefs, we think about ideas like female orgasm is only possible via vaginal intercourse. Penile erection is essential for women's sexual satisfaction. A real man is always ready for sex and must be capable of satisfying any woman. Failing to keep an erection is embarrassing. A firm erection is a sign of masculinity. And this is an important one. For a lot of men, ED is actually a loss of masculinity, which causes embarrassment, which causes even more performance demand and failure anxiety. Apart from these cognitions, we also know that attributions play an important role, having the idea that they have no control, that it's just kind of something that happens and they cannot control it. Also feelings of helplessness. They have the idea that they cannot help it, that they cannot really do something to get an erection. They have lower self-confidence, negative self-schemas, often also very negative body image. There's a lot of worrying, a lot of catastrophizing, a lot of thought control strategies, which all contribute to exacerbating the erectile dysfunction. Also, what we see is a lot of perfectionism often. There's somatization. We do see a link with personality factors, that men have more neuroticism. And if you have more neuroticism, then there's a higher chance to develop ED. There's also an effect of stress and life circumstances, like having a new career, the birth of a child, maybe also the COVID situation can increase erectile dysfunction because of the stress, because of the cognitive distraction. And what is also really important is depression and anxiety, because we clearly see that there's a reciprocal relationship between depression and ED. So there's a higher chance to develop ED when you're depressed and vice versa. So as clinicians, it's really important to screen for depression and anxiety when assessing and treating erectile dysfunction. Obviously, there's also the social component, the social and relational factors. And what is important is that we need to see ED as involving a shared stressor. It's challenging for both partners. It's not an individual problem of an individual patient. It's not the problem of the male partner. It's also the problem of a female or male partner. What we often see is that men tend to ignore or avoid the problem. They don't want to acknowledge it. So it's often the partner that is aware first of the problem. So that's why it's really important to consult the partner as well, and to involve the partner in assessment of erectile dysfunction. We often see that changes in sexual function in one partner go along with changes in the other partner. And research has shown that about 62% of the partners reported sexual problems, and most of these problems were actually the result of ED. So they actually occurred after ED has been diagnosed in men. So it clearly is that the ED in men will also impact the sexual function of the partner. We do see that there are more psychosexual issues in partners of men with non-organic ED. And we can clearly see research has shown that the quality of the sex life in general of the partner is reduced, because often men tend to avoid sexual situations because they are afraid that they need to perform. So this means that there is reduced intimacy, so less touching, less kissing, less foreplay. Also, it's often sort of an avoidance of intimacy because men are afraid that if they start intimacy, they will need to continue and need to perform. So they actually tend to avoid any type of sexual or intimate stimulation. And this is really devastating for partners of men with ED. There are clearly psychological effects on the partner. There are a lot of trust issues. What we see is that often the partner relies on the spontaneous erection as a sign of sexual attractiveness. So when the man does not have this spontaneous erection anymore, they start to doubt themselves. Am I not attracted anymore? Is there infidelity? Is he betraying me? So there's a lot of trust that needs to be dealt with in case of erectile dysfunction. What we see is that obviously the prevalence of ED increases with age. So also women may face their own sexual changes because of the menopause, for example, when men develop ED, which also has an impact on sexual recovery, because we often see that also women tend to report more pain problems, decreased sexual desire, which has an impact on treatment. Communication problems. A lot of couples have difficulties to openly talk about sexuality, to communicate about what they like and what they don't like. And this is really important when you're facing ED, because then it's important to be more explicit towards the partner to indicate what is going wrong. What is also important is the partner plays an important role in the decision-making about treatment, whether they will take medication, whether there will be penile prothesis. This all also depends on whether the partner is still motivated to engage in penetration and to engage in sexuality. So the desire level and the sexual status of the partner will play an important role in deciding which treatment is the best treatment for this person. Try to prevent disagreement about the treatment choice, and because we do see that when there's a disagreement in which treatment they prefer, that this has actually a negative prognosis when it comes to treatment success and the course of treatment. And obviously also consider the role of male sexual partners. We're not only talking about female sexual partners. Obviously, ED also occurs in non-heterosexual relationships. So when we know that the etiology is biopsychosocial, that we need to take into account biological factors, psychological factors, relational factors, then also the assessment of ED should be biopsychosocial. So this means that we need to perform this assessment in a multidisciplinary setting, and that we need to involve the partner in the assessment of ED, because a partner can give very important information on the development and the course of the erectile dysfunction, which is often information that men are not aware of or are a little bit ashamed or embarrassed to talk about. So what we standard do in assessment is obviously the physical examination, the lab testing, the medical history. This is what urologists and doctors will do. But what is also important is to add a psychosexual history. It's really important to have this thorough, detailed history of their psychosexual factors. And the problem is that a lot of urologists and andrologists lack knowledge and skills to perform this psychosexual history. So it's really important that we pay more attention to this in trainings. And also, if you're not trained well to do this psychosexual history, try to team up with a sexologist, try to assess in a multidisciplinary setting, so that at least you have the full picture of the erectile dysfunction. So regarding the psychosexual history, I'm not going to go into detail for all these different components. You will get the slides, but these are themes that we mostly want to ask about in the psychosexual history, like talking about the sexual response cycle, the meaning of the complaint, the influence on the relationship, but obviously also the sexual development, the relationship history, negative experiences, and so on. So treatment, most often treatment follows a stepwise program, growing from less invasive to more invasive treatments. Lifestyle changes, pelvic floor exercises have been proven to be valid in terms of erectile dysfunction, medication, mechanical devices, surgery using the penile prothesis. But what we often see is that when people use these medication or penile prothesis, that more than 50% of the couples do not adhere to medical aids. And one of the most important reasons not to adhere to these medical aids are the idea of, it's not spontaneous. It's kind of an artificial intimacy to use this prothesis or to take medication. There's embarrassment, there's still performance anxiety because of the medication, there are new demands, they need to perform again. So they enter this vicious circle again. So if we look at the reasons why people actually stop with these medical treatments, it's clear that psychotherapy and counseling can actually add to the importance and the effectiveness of this medical treatment. So that's why what we see in general is that often doctors and patients prefer a medical treatment because they are viewed as more efficient and more like a quick fix, because in psychological treatment, you never know when it's going to end. It's talking about relationship issues. People are afraid to talk about it. So they actually prefer a medical treatment. Although we do see that when you combine medical treatment with psychotherapy, this leads to better outcomes, less dropout. So it's important actually to add psychotherapy to promote the treatment adherence, to integrate this medical treatment into the sexual relationship, and to focus more on these underlying maintaining processes like anxiety, negative thoughts, communication. So what is clear is that the treatment is not cause specific. When we look at medication and surgery, this is focused on treating the symptoms, restoring the erection, and you can use medication also when there's a non-organic cause. Psychotherapy is focusing more on the underlying factors, the maintaining mechanisms. It's about the meaning and the function of the ED. It's about this cognitive distraction, performance demand, impact on the relationship. So also when there is an organic cause, it's important to add psychotherapy to tackle these underlying causes and mechanisms. So what about psychotherapy? We often start, first of all, with psychoeducation, because we need to inform them about the sexual response cycle. We need to make people feel at ease to openly discuss about sexuality. And then we target 4 important components in the treatment, which is in the first place, anxiety reduction. We use sensitive focus exercises. So this means that 2 times in the week, partners need to touch each other each 10 minutes. And there's a penetration band. So they touch each other, they focus on their bodily sensations, but they cannot engage in penetration just to stop this performance demand. So men know that they can relax a little bit more, enjoy the sexual stimulation again, or just the touching without needing to perform. This is a first important stage. Then we obviously do the cognitive therapy, because we also need to challenge these dysfunctional thoughts, these performance ideas, this male macho beliefs. And what is also really important is to increase the sexual stimulation, to make sure that men get the right stimulation, to maximize the stimulation, and to provide more, longer and more direct stimulation of the penis. Also try to focus less on the penetration and explore other parts of sexuality. So just again, to reduce this focus on penetration, to reduce the performance demand, try to associate sexuality with positive experiences again. Planning sexuality is also really important, because often couples in long-term relationships think that sex spontaneously pops up out of the blue, but this is not the case. You need to make the effort, you need to plan it a little bit, you need to sort of create opportunities so that sexual desire can emerge. And then obviously working on communication and couples is really important, because there needs to be a focus on the relationship. 1, the partner does not feel attractive anymore because of the ED, so you need to tackle that as well. The partners also have sexual problems, so they need counseling too. We know that when ED is treated well, that actually also improves the partner's sexual function and satisfaction. So again, it's important to include the partner in therapy sessions. Try to look at relationship conflicts, because often what we see is that there can be power imbalances, or that ED is a symptom of an underlying relationship conflict. So in case of severe conflicts, obviously you need to refer for relationship therapy, but you need to address this relationship part in your therapy as well. Communication skills, so learning partners to openly talk about what they like and what they don't like. Focusing on intimacy, planning date nights. Again, as I said before, sexual desire does not spontaneously pop up out of the blue. You need to make the effort. So this means that one night in the week, for example, you create an intimate atmosphere so that sexuality can emerge. Otherwise, our agendas are fully packed and sex will not appear. And obviously working on the relationship climate, because when there's more relationship satisfaction, this also often results in more sexual satisfaction, especially because there's a stronger motivation to actually engage in sexuality. There have been some new developments, mindfulness, for example, which is more about meditation, about present awareness, moment-to-moment awareness, being in the present, not being distracted by thoughts, but focusing on your bodily experiences, which would be also very helpful in case of erectile dysfunction. Also, acceptance and commitment therapy. This is really interesting when there's erectile dysfunction, for example, that is irreversible after prostate cancer or other medical diseases. It's learning to accept and to live a valued life despite the erectile dysfunction, and see how you can still enjoy sexuality and enjoy sexual intimacy apart from the erectile dysfunction. Yoga has also been investigated because this is mainly about relaxing, about being in the moment, about getting in touch with your own body. And lately also e-health has been developed. E-health, especially in COVID times, have become really popular and should be investigated more in the future, because we can sort of reach a lot of more people using e-health applications. So in general, when we focus on treatment effectiveness, I think it's really important that when we want to evaluate whether a treatment is effective, we often think, okay, restoring the erectile function, that's our main outcome variable. But it's not only about restoring erectile function. It should also be about satisfaction with erectile function, about the quality of your sexual life, about sexual confidence, and especially pleasure, whether people still experience pleasure from their sexual life. And what is also really important is that when you decide on a treatment, it's about shared decision-making, which means that you cannot just force a treatment on a patient. It's really about what they want, what the partner wants, and it's really about talking what is the best treatment for this person, whether it's an organic treatment, a medical treatment, or non-medical treatment, whether it's an organic cause or not. It's always a shared decision between the patient and the healthcare professional. Thank you for listening to my part. I give the floor to Emmanuele, who is going to address more of these issues now.
Thank you so much for this wonderful presentation, Marieke. So let me try to share my screen. I hope that now you can see it. Meanwhile, we have several questions coming, some about therapies, the comorbidities with premature ejaculation, and so on. So I think that we may address them later after my talk. Those are my disclosures, and I'm taking the occasion to thanks, first of all, the Society for inviting me to discuss, after Marieke, my experience with an non-organic erectile dysfunction, mainly focusing on the therapies and on the medical therapies. This is because I am a medical doctor. Actually, I'm a professor of endocrinology and sexual medicine in the Rome University, but also I am also professor of psychoneuroendocrinology into the Faculty of Psychology into the Rome University too. So the biopsychosocial model, which has been introduced so well by Marieke, is definitely a wonderful standard, a wonderful way to understand how to use drugs, how to use the pharmacotherapies in non-organic erectile dysfunction. But I think that we may also go into a step ahead introducing what I called the system sexology, why there is a need to use another term which is not eliminating the classical biopsychosocial model. It is because the system medicine or the system sexology is indeed an new perspective, which is considering not only the well-known psychosomatic flow. You know, psychosomatic means that something which is acting into the mind may act also into the body, into the sexual behavior. But in this way, we have to consider also the somatopsychic perspective, which is the vice versa. In other words, is something which is acting into the body, let's say an effective drug, which is acting indirectly, but into a very powerful way, also into the psychic habit, into the psychological aspects. And this is the matter of the system sexology, which is an interdisciplinary field of the sexual medicine as well of the psychosexology, which is trying to find the systems of the human sexuality, considering them as an integrated whole, which are incorporating historical, let's say religious, let's say theological, let's say political, as well economical. Think about the crisis, think about the pandemic, for example, to putting together with the biochemical, the physiological, as well the environmental interactions, which are producing sexual dysfunctions, which are affecting the therapies, as well the success of the therapies themselves. System sexology is a part of the so-called system science, which is quite a fashion way to talk about science, as well as system psychology and system biology, which is considering a complex interaction within the human body in the light of the genomics, in the light of the behaviors, in the light of environment, with the final aim to produce a new model and exhaustive networks of interaction, which are to be considered bona fide, able to produce or to affect sexual health and finally the success of the therapies, and in our case, mainly of the pharmacotherapies. This is a quite a famous article wrote by a giant in psychosexology, Stan Althoff from the United States. And it is very interesting what he wrote more than 10 years ago. He said that there are several factors which affect or change the sexual medicine in general and the sexology in particular. The techniques of mindfulness that Marieke was talking just a few minutes before, for women mainly, because women are very much concentrated, are able to better understand the importance of those techniques, but of course that they will be also used successfully also in male. The internet therapy and some other issues related to the pain, that those have been considered by Stan as main issues as a novelty. But what is very fascinating is the fact that he said that the most important one is the combination, the integration of the traditional psychotherapy with the new medical therapies. The main aim, I think, of both Marieke and mine is to convince you that the psychological reductionism is terrible, is a terrible way to fail to not to do a good therapy exactly as it is the medical reductionism. So having in mind only the psychological perspective and not considering the power of the pharmacotherapies is really wrong, as it is to use just the pills without considering the impact that they may have in the patient as well into the couple. Stan was also the first author of this very nice article published in the Journal of Sexual Medicine, basically dealing with the blue pill with the sildenafil and showing in some way the loop which exists from a successful therapy, from a successful treatment in producing not only an increase in the erection hardness score, which is one of the parameters you can use to understand the success of a PD5 inhibitor therapy, but also into the maintenance of the erection, which is also tremendously important, into something which is really psychological in nature, which is the confidence. The confidence into the ability to obtain and to maintain the erection. So if you make me allowed to say something which is really not perfectly correct, but easy to understand and also easy to share with the patient into your daily clinical practice, a good pharmacotherapy is in somehow also a psychotherapy. So in other words, is affecting, changing, ameliorating the psychological habit of the patient if it is used successfully. Anxiety is reduced, and we have a number of evidences also using good validated, very well validated psychometric tools showing that sexual activity itself is reducing anxiety. Good medical therapy itself for erectile dysfunction, non-organic erectile dysfunction, is reducing anxiety. So in other words, we can say that PD5 inhibitors successfully used and used into a correct way are anxiolytic therapies. I know that this again is not correct. They are not GABAergic treatments, so they are not to be considered really as anxiolytic, but they are indeed anxiolytic as well, antidepressant, as it is sexual activity, as we demonstrated in January in issue of a Journal of Sexual Medicine, showing that the people who are making sex are lower level of anxiety and depression during the lockdown due to the COVID. But I wanted to be back on my expertise of endocrinologist and medical doctor, showing what I do mean when I say that the somatopsychic evidence may improve our skills, our ability to successfully treat erectile dysfunction due to non-organic causes. In this case, I wanted to introduce you this study, which has been called EndoTrial because it has been done by the Italian Society of Endocrinology, pardon me, many years ago again, which was the first study comparing head-to-head three different PD5 inhibitors available at that time, sildenafil, tadalafil, and vardenafil, using an objective way to measure the success, which is the echo-color Doppler. So the aim of the EndoTrial were to compare not just with the International Index of Erectile Function Index, which is a way to measure subjectively the efficacy of PD5 inhibitors, but also measuring an objective with an objective instrument, which is the Doppler, comparing sildenafil used at 50 milligrams with sildenafil at 100 milligrams, together with the highest available doses of tadalafil 20 and vardenafil 20. And basically, we measured the hemodynamic changes over the 8-week, the 2 months treatments with those drugs. And what we discovered is basically that all drugs have been found in our setting able to ameliorate, to change the parameters, the subjective parameters of the International Index of Erectile Function. And of course, some have been found a little bit more efficacious, apparently more efficacious, but no one of those data has been found significantly different from the others. So all treatments have been successful in improving the International Index of Erectile Function parameters. However, when we measured the hemodynamics as measured by the Doppler, we found that only sildenafil was able to change the performance, the vascular performance in those patients. Remember that those patients were not just with organic vascular erectile dysfunction, but also with non-organic erectile dysfunction. This is quite a key point, because into the patients with non-organic erectile dysfunction, the lack of sexual activity due to the psychological risk factor may produce in time, during the time, a reduction in the vascular performance too. So the primum movens, the start is psychological in nature or with psychological risk factors, but the lack of the sexual activity is producing two things. First, the vascular inability to perform into a good way because of the endothelial dysfunction coming from, and the second, the endocrine one, the reduction in testosterone levels, which has been found as a consequence of the lack of the sexual activity due to the non-organic sexual dysfunction too. So when measuring the resistive index, which is considered the parameter representing the vascular performance, sildenafil was the unique one into the high dose of 100 milligrams, able to change the vascular performance of the patient treated with. But 100 milligrams is a dose very, very efficacious, but with some side effects, which have been considered not present into the genial dose of 75 milligrams, which is present into the new orodispersible sildenafil, now available in several countries in Europe. The film, orodispersible film of sildenafil is also delivered into a middle dose between 50 and 100 milligrams. And this is very important also from a psychological perspective, because you can say that this dose is having the efficacy of 100 milligrams without the side effects of the same. And we are now currently studying, using the Doppler again, if really 75 milligrams are sharing with 100 milligrams the same efficacy or a similar efficacy, with the very low side effects of 50 milligrams. The last point that I wanted to discuss with you, my colleagues, is really psychological in nature, but again, matter of the clinical experience that everybody who is using PD5 inhibitors experienced in his clinical life. How many times the partner of the patient you wanted to prescribe a PD5 inhibitor told you, as into the cartoon, no, don't use Viagra, don't use PD5 inhibitors, because they may reduce my sex appeal, because they can be dangerous or harmful for the patients. And this has been considered in many, many reports as a main reason for the dropout, also because of the stigma of being treated with a well-recognizable, well-known PD5 inhibitor as a major issue for the stigma of being impotent. So for all those reasons, we can say that many partners are strongly against the use of PD5 inhibitors in the therapy. And I call them as PD5 inhibitors jealousy, or Viagra jealousy. The Viagra jealousy is something which may really affect the success of the therapy and may increase the reason for the dropout and could be considered as a dramatic limiting factor for those therapies. The fast dissolving oral film, the sildenafil Orodispersible film, is based on the hydrophilic polymers containing the drug as well other excipients, which are to be considered as a form of using PD5 inhibitors absolutely unique, with a peculiar ability to preserve what? The male intimacy. The male intimacy with himself, having a convenient and discreet dosage form. What does it mean, discreet? It means that it's not like a pill, it's like a film, which can be into the pocket of the patient, which is dissolving the mouth without the need of the water. The need of the water is tremendously important because it's representing for the patient the fact that he is taking a drug. And different from the other pharmaceutical formulation, even if it is with the same power, and as I said, with a new power of the 75 milligrams dosage, not easily recognized as a drug, so that I use a new term as the unique intimacy sparing PD5 inhibitor, because it spares the intimacy of the patient with himself, not showing that he's using a prescription drug. And this is meeting a major psychological concern, and it is increasing the success of an integrated, again, as I said at the beginning, system therapy, considering all those aspects which are so dramatically important for the success of the therapy itself. So my colleagues, in order to give you enough time to share your talks, to ask your questions, and to give us the possibility to discuss with you, and in order to preserve the time, I'm just going to finish my short talk and giving you my take-home message. Of course, the lifestyle change which is a psychological therapy, which is a behavioral therapy, is not just a medical one. The changes in the lifestyle are the first gold standard therapeutical aim of the ED treatment. And this is to be considered because it's tremendously important. And the psychotherapy and the medical therapy are to be always to be considered a second task, a second therapy after the changes in the psychotherapy, as far as it is so well known, so well demonstrated that the lifestyle mistakes are so much affecting the sexual life and our destiny into the bed, if I can say something like that. Second point is that, as Marieke said, and I am strongly in favor of it, all the patients with erectile dysfunction, as well all the patients with a sexual dysfunction, irrespectively of the main risk factor, are deserving psychological attention, psychological diagnosis, and counseling and psychotherapy when needed. The counseling is not something which is a duty of the psychologist. The counseling is a duty of the doctor. And giving the pill without the counseling, just saying, take the pill and you will see that tonight you will be successful, is a perfect way to make mistakes and to produce the so frequent dropouts that the pharmacotherapists have, which has been counted as 40% of the patients dropping out from the pharmacotherapies, not because they are unsuccessful, not because of the price, not because of the side effects, but because of a lack of counseling. The third point is that the power of the pharmacotherapies is in fact dramatically reduced when the drugs are used without a diagnosis and without the counseling. So the final take-home message, my colleagues, is that to listen to the patient, to understand their needs, to address their needs, and also some particular needs, like that one of discretion, that one of the intimacy, is the unique way, if not the principal avenue, to obtain the main aim of sexual therapy, of sexual medical therapy, which is the therapeutical success. And again, I would like to thank you for listening to this presentation, and Marieke and I will be more than happy to be with you in discussing the possible, your possible questions.
Thank you very much, both of you, for these excellent presentations. And I feel like you really hit it home, Emmanuele, in this last slide with the take-home messages. There's not much to misunderstand there. We have, so thank you for that. We have several questions. A lot of them are very specific. We're going to try to tackle them. I'll sort in them a little bit. The first one, and this has been asked a couple of times, is about pelvic floor exercises. What are the role of those, in your opinion, in erectile dysfunction?
I think the more recent studies have shown that pelvic floor therapy can be effective, because we often think pelvic floor therapy, we ascribe this to women, because women have the pelvic floor and they have to train it. We have the Kegel exercises, but these are also effective for male problems, because we do know that the pelvic floor is involved in sexual arousal and orgasm, and men also have a pelvic floor. So learning to relax the pelvic floor would be a good way to treat, it will not solve the erectile dysfunction, but it can contribute to relaxing the muscle tension around the pelvic area.
If I can make a comment to that, several of the studies and what's mainly discussed is pelvic floor training, like strengthening the muscles to increase the erectile function.
Yeah, but the thing is, it's always the matter is gaining control over, and what we often see is that we focus too much on the strengthening. That's also what the Kegel exercises and in women, which is always about strengthening pelvic floor. But the crux is really in about learning to stretch and strengthen and relax, and it's this relaxed part is the most difficult part, because we all know how to squeeze our pelvic floor, but we have more difficulties to relax. So it's really about learning to alternate between strengthening and relaxing, and that's the crucial factor for treating sexual arousal problems.
And I was going to say, I agree completely with you. I think relaxing the pelvic floor, talking about orgasm and enjoyment and the lack of pain, is actually much more interesting, and the evidence for that is actually better in my opinion as well.
Yeah, that's true.
What exercises do you specifically recommend patients? I guess the question goes for both of you.
I think if I can start with the psychological part, and maybe then Emmanuele, you can add to this. We often use masturbation-like exercises, which is more about learning to gain control, and it's about sort of building up your erection. And then when you have a strong erection, you let it go, and then you build up again and you let go. And you do that actually 4 or 5 times after each other, and then you continue. And it's just a matter of learning. Well, what we see is that often that people have a peak in sexual arousal, and then suddenly they are distracted, they lose their sexual arousal and they panic. It's learning, well, you don't need to panic, you have control. So if you lose your erection, you just focus on yourself again, you stimulate yourself again, and then you can gain a new erection. It's really about gaining self-confidence. So masturbation exercises, using guided stimulation, fantasy training can all help to sort of maximize the sexual arousal.
Yeah, it is fascinating what Marieke said, also because the masturbation is an issue which is not so frequently addressed by many doctors who are dealing with sexual dysfunctions, and the masturbation has also been related when excessive or not correct masturbation with erectile dysfunction too. So we have to really take care about it. When I was listening the questions and the answer of Marieke, I was thinking about what I wrote in Nature Review Urology a few months ago with respect to the loss of control over erection and ejaculation. So this is quite an important topic. The fact that some patients, and it is indeed what Marieke said, and I totally agree with her, some patients do experience a loss of control in both erection and ejaculation, and the exercises which are, or the drugs which are increasing the level of controls are more than welcome. And you mentioned, Michael, the Kegel exercises, which are traditionally used into the female setting, as well into the premature ejaculation treatment. They may have also a role, but I like tremendously what Marieke said about the need to teach to the patient also to relax, not only to contract the muscles. And another interesting point is the fact that when you are prescribing exercises to the patient with a psychological risk factor, you have to consider that there is a role for the exercise itself. In other words, sometimes it's not so tremendously critical which kind of exercise you are prescribing to the patient. It is critical to reduce the anxiety to perform giving an exercise. Giving an homework is itself, I don't want to say that they are not important. They are definitely tremendously important, but consider the power of giving an homework or to give an exercise, because it is reducing the anxiety to perform. As again, as Marieke said, the perform anxiety is one of the main risk factors for the impotence, for the erectile dysfunction.
Okay, thank you. And a quick last question. Do you worry about dependence on PDE5 inhibitors? If you prescribe them for young men with non-organic ED, kind of as a crutch?
Not really. I think it's really important. It helps them to gain self-confidence, and it's really about learning them, because as I said in my presentation, it's really about this constantly monitoring their bodily sensations. And if you give them a pill that you can say, well, you don't have to monitor your sensations because you will have an erection. There's something medical going on. So they can learn to relax a little bit more. They can learn to focus on the sexual stimulation again. And once they had some successful experiences, then you can sort of start reducing the PDE5, and it actually works really good in non-organic ED.
Just to add just a few words, the risk of this is very low when there is a good relationship with the doctor. Yeah. On the contrary, when the patient is using itself without any kind of control, there is a risk of, let's say, of addiction. And it is indeed, I can understand the risk in the young people, but the risk of the addiction to erectile dysfunction is worse with respect to the risk of the addiction to a therapy.
Exactly.
It is a joke, but it is quite true, actually.
I understand. I like the way you phrased that. So there are a lot of other questions, and this has been an extremely interesting webinar, and I think that attests to that. But unfortunately, it is 9 o'clock, and we do have to end. So I want to really thank our speakers. These were excellent presentations and answers afterwards. I want to thank IBSA very much for supporting this webinar and for continuous support of the webinars. This really helps spread the knowledge and bring sexual medicine forward. And of course, I want to thank all of the participants for being here tonight. More than 150 participants. This was impressive. So thank you very much, everybody. And keep a look at the website for further webinars. Thank you.
Thank you.
Goodbye.
Good evening. Goodbye. Thank you.
Bye, everybody.
Ciao. Ciao.